Okay. Good morning, everyone. My name is Martina Penazzato, and I'm the Pediatric Advisor for the HIV Department in WHO in Geneva. And I will be co-chairing this session with my colleague, Annette Son.
Annette Son from Treat Asia, Amphar in Bangkok. Thank you.
So I'm sure that if you're here today, you know very well that our work on pediatric HIV is not done. There's a lot to do. We are reaching only 43% of HIV-exposed infants within their first 2 months of life with testing, and we're only providing treatment to 43% of the 2.1 million children that are estimated to be living with HIV globally. We know that the first 90 is undoubtedly the biggest challenge for all population, but particularly for children, and you will hear a lot in this session about this. So we have 6 great presentations waiting for us. Each presentation will have 10 minutes, and we'll keep a couple of minutes for question and answers. So without further ado, I'd like to invite the first presenter, Theresa Wolter from the Elizabeth Glaser Pediatric AIDS Foundation, who will present on trends in pediatric HIV testing across 6 African countries.
Great. Thank you, Martina. Good morning, everyone. On behalf of my EGPAF colleagues listed here, I'll be presenting some analysis that we did on some of our aggregate programmatic data, looking at trends in pediatric HIV testing across 6 different African countries. So across 5 quarters, from July 2015 to September 2016, provider-initiated HIV testing and counseling for children and young adolescents was expanded and optimized at nearly 2,000 sites in Côte d'Ivoire, Kenya, Tanzania, Malawi, Swaziland, and Lesotho. HIV testing was offered through a range of facility and community-based service delivery points and approaches. At the facility level, this included the offer of HIV testing in outpatient and child-centered services such as TB, under 5, and nutrition services. Index case contact testing was also offered at the facility level. At the community level, door-to-door testing campaigns and community campaigns were offered in targeted areas, along with home-based index case contact testing. Through this initiative, nearly 800,000 children and young adolescents were tested for HIV, with a substantial majority of the testing taking place at the facility level. Of the 791,000 children tested for HIV, 9,688 tested positive, representing 1.2% positivity. From Q3 2015 to Q3 2016, we saw a 274% increase in the number of children tested and a 60% increase in the number of children identified as HIV infected, demonstrating that a rapid scale-up and optimization of pediatric PITC is very feasible when coupled with appropriate resources and prioritization. The 9,688 children and young adolescents newly diagnosed through this initiative represents 8% of the total population of 128,000 currently undiagnosed HIV-infected children and young adolescents in these 6 countries. So this very busy graph represents HIV testing and positivity in children and young adolescents aged 0 to 14 years across the 5 quarters and the 6 countries. The blue bars represent the total number of children and adolescents tested for HIV, and the colored lines represent the positivity by quarter and country. The total positivity across all 6 countries decreased from 2.2% in Q3 2015 to 0.9% in Q3 2016, although the number of children diagnosed in these same quarters increased from 1,492 to 2,393 in the final quarter. As we would expect, HIV positivity decreased in each country over the 5 quarters, as we continue to identify more HIV-infected children, and the remaining number who are undiagnosed becomes smaller and smaller. If you'll look, you'll see that Q3 2015 in Malawi is quite an outlier. It's about 5.3% positivity. and there were actually no unique or additional interventions that were done during this quarter, so it appears that this was just an outlier amongst our data set. The most significant decreases in positivity across the 5 quarters were in Kenya, Lesotho, and Swaziland, where HIV positivity decreased amongst the 5 quarters by at least 50%. We also analyzed HIV positivity in 3 countries where we had this data available by age group: Côte d'Ivoire, Lesotho, and Swaziland. 270,000 children and young adolescents were tested across the 3 countries, with 2,392 testing positive, representing 0.9% positivity. While these countries each have unique HIV responses, including very differing rates of HIV prevalence, adult, adolescent, and child PMTCT and ART coverage, we see a similar trend in HIV positivity among children aged 0 to 4 years, 5 to 9 years, and young adolescents aged 10 to 14 years. Across all 3 countries, the lowest positivity is in children aged 0 to 4 years, then increasing in the 5 to 9 year age group, with the highest positivity amongst young adolescents ranging from 0.8 to 3.6%. One additional point that I would make about this 3-country context is that the data is represented here from sites at which EGPAF has been supporting for several years. So we may see some bias here given the fact that there's been a significant PMTCT program at a lot of these sites for several years. So continuing in these same 3 countries, Côte d'Ivoire, Lesotho, and Swaziland, these graphs show the proportion of children and young adolescents tested for HIV disaggregated by age, and the proportion of children and young adolescents tested positive disaggregated by age. The orange represents children aged 0 to 4 years, with the blue representing children aged 5 to 9 years, and purple representing young adolescents. Comparing the 2 graphs, we can see that HIV testing approaches in Lesotho are largely aligned between the proportion of children and young adolescents being tested and the proportion identified as HIV infected. In Côte d'Ivoire and Swaziland, we see a more significant difference in the proportion of young children tested. For example, in Swaziland, only 23% of those tested were children and young adolescents aged 5 to 14 years. However, this group represents 50% of those testing positive. And this data really reiterates a point that we all already know quite well, which is that with the orientation of health services for infants and young children, we have more opportunities to identify HIV-infected children in the under age 5 group, and it becomes increasingly more difficult as children age out of these services and have fewer interactions with the health system. So moving now on to Kenya. We analyzed data on HIV positivity among children and young adolescents disaggregated by service delivery point at 135 sites in Western and Nyanza province in Kenya. The data shows HIV positivity across age groups 0 to 4 years, 5 to 9 years, and 10 to 14 years at TB, nutrition, outpatient, child wellness clinics, and inpatient services. So not surprisingly, the highest positivity across all 3 age ranges is found in TB clinics, ranging from 9 to 20%. The second highest positivity was found in nutrition clinics, ranging from 1.7 to 5.4%. HIV positivity in outpatient, child wellness, and inpatient services for all age groups was less than 1.5%. And the data here represents 250,000 children and young adolescents who were tested and 1,500 who were positive. So staying in Kenya, this graph shows the proportion of children and young adolescents testing positive by age and service delivery point. Outpatient services, which are highlighted in green, were the service delivery point which accounted for the highest proportion and number of children testing positive, ranging from 60 to 69% of children and young adolescents tested. While HIV positivity is high in TB services, again ranging from 9 to 20%, this represents only 40 children and young adolescents identified as HIV infected. Conversely, while HIV positivity in outpatient services ranged from under 1% to 1.36%, This represented the identification of 968 children and young adolescents. This data here highlights a trend that we're seeing across several countries, particularly in Kenya, which is the placement of HTS counselors at facilities and really having a triage approach to make sure that all children and adolescents who are seen at a facility are first tested before they go on to their services. So I think that we're going to increasingly see OPD as the center of identification for children and adolescents. And this really speaks to the possibility and the potential value in a screening tool which allows us to more effectively screen and identify children at risk in OPD services. So finally, we expect that yield among children and young adolescents newly tested will continue to decrease as the number of undiagnosed HIV-infected children and young adolescents continues to decrease, as treatment continues to expand and as PMTCT both further expands and continues to be effective. Reaching and testing undiagnosed HIV-infected children and young adolescents will become increasingly more challenging in this context, and the data on the most effective approaches is going to be even more critical. More targeted testing approaches tailored to the context and data on the most effective approaches may prove that targeted approaches are more effective than broad approaches. And finally, while HIV positivity should absolutely be a factor in determining the effectiveness of testing approaches, the absolute number of children and young adolescents identified has to be taken into account, particularly as our data from Kenya demonstrates that high positivity may not necessarily translate into a high number of children identified. Finally, a thank you to my EGPAF colleagues in these 6 countries, as well as PEPFAR, ELMA, and CIF for their support of our work.
Thank you very much, Theresa. So this paper is now open for questions. So please, get close to the mic and introduce yourself before asking a question. Thank you.
Thanks very much. I'm Saeed Ahmed. I work for Baylor in Malawi. So one of the things we're struggling with is perhaps a little bit of contradiction between what you had put up as your last 2 conclusions. And I think all of us are thinking about this in that we want targeted testing, but high positivity yields don't have high numbers. So do you have some thoughts on what those targeted testing, where they would be that would give you high yield and high numbers? Because, I mean, from our experience, we're seeing more that kids are sprinkled through the community in different areas, and so what those targeted testing strategies should be is a challenge.
Great, thanks, Saeed. We're also struggling with this, which is part of what led us to do this analysis. Is we really realized that we needed to better understand where we were identifying children. There were some approaches that we thought were going to be highly effective, like the testing of children of index cases. We found that was actually a pretty low yield and a pretty low number. What we've found so far to be I would say one of the more effective approaches is what we've been doing in several countries is the placement of HTS counselors in OPDs so that we're testing children. The challenge, of course, is then we're testing tens of thousands, if not hundreds of thousands of children. What we're now doing in 4 countries is piloting a screening tool to see if there are some universal questions that we can use to identify children as they pass through OPDs, and then if there are also some locally relevant questions that we can add to that. But again, similar to what you've mentioned, we've found that broad community-based testing has been less effective, and also even testing in some of these child-centered services has produced lower numbers than what we were expecting.
A quick second question, yes?
Yes, Philippe Mselati, IRG, France, Côte d'Ivoire. Well, it's in the same direction, I would say. One of the most effective places where to find children should be people living with HIV associations. But it seems that you didn't work at all on that, because it's a big, it could be quite effective, I think.
Thanks for that comment. We did actually work with the children of parents and in households where people were living with HIV. And as I was mentioning, we were actually a little surprised that particularly for children under the age of 15, the positivity was a lot lower than we thought. So one of our hypotheses is that it's potentially because the index case client may be a mother who's been on ART for a while. So one of the things that we're doing now is some more analysis around what happens when you use different people as the index case client. Do you get a different type of yield, for example, if a man is the index case client as opposed to a mother from PMTCT services?
Thank you very much. So now I would like to invite Nicola Okoko from the Kenya Medical Research Institute. She will take us through her paper entitled Evaluation of the Impact of the Accelerating Children HIV/AIDS Treatment Initiative on Pediatric and Adolescent HIV Testing and Yield in West Kenya. Sorry.
Good morning, ladies and gentlemen. I'm Nicolette Okoko. I work for Kenya Medical Research Institute, as has been mentioned. On behalf of the co-authors, I wish to share with you briefly about evaluation of the impact of Accelerating Children's HIV/AIDS Treatment Initiative on Pediatric Adolescent HIV Testing and Yield in Western Kenya. No conflicts. Now, despite declining new infections, pediatric HIV remains significant, with 150,000 new infections annually and 1.8 million children less than 15 years living with HIV globally. Now, less than a third of children have ever been tested in HIV in Nyanza region in Western Kenya. Therefore, many children that are eligible for testing in this high prevalence region have not been reached. So Accelerating Children's HIV/AIDS Treatment, otherwise known as ACT, was a public-private partnership to provide a strategic response to treatment gap for children. It was a 2-year project launched in 2014 at the African Leaders Summit, and it aimed to initiate about 300,000 children with HIV on treatment in 9 priority countries, Kenya being one of them. Our objective was to examine whether activities under ACT initiative increase testing and identification of children with HIV. So FACES is a family-focused comprehensive HIV prevention, care and treatment program in Nyanza region of Kenya. It was launched in 2004. And within this evaluation, we implemented activities under ACT initiative in 144 health facilities in 3 counties, that is Homa Bay, Kisumu, and Migori in Western Kenya, between October 2015 to September 2016. Now, Homa Bay, Kisumu, and Migori counties are among the highest ranked HIV incidence counties, where 65% of our new infections in Kenya occur. So 85% of our facilities were rural, a vast majority, and 2/3 were small dispensaries, with only 8% being sub-county and county hospitals. Now, our interventions consisted of a suite of strategies targeting the first 90. So we focused a lot on family testing, which utilizes family information table to prioritize family members of index patients. We conducted family testing chart audits to follow up on testing. We identified service gaps and engaged 69 additional HTS counselors. We renovated and allocated space for HTC to create privacy and richer counseling interactions. We also conducted targeted community outreaches, targeting areas frequented by adolescents, like the churches, the discos, and big events like the World AIDS Day. Our mothers also received text messages to facilitate early infant diagnosis. Now, all our 144 clinics participated in this evaluation. Our sites were assigned to either intervention or control, dependent on whether the intervention was actively being implemented at a given month. And now this allowed determination of the impact of individual interventions, as you'll see from the results. We collected monthly data disaggregated by age, category for children tested at each facility, and on the number of HIV positives identified. We then used negative, binomial, generalized estimating equation models to produce incidence rate ratios for each intervention, comparing sites that conducted a strategy in a given month to control sites that did not concurrently conduct that strategy. It's important to note that we adjusted for repeated measures, geographical locations, health facility tier, and test kit stockouts during each month. Now, during the ACT initiative, the mean number of children increased significantly across all age groups, as you can appreciate from the graph. If you look at the blue line, the mean number of infants tested per facility actually increased from 2.8 to 7.2 in September, and this was significant. I know the line appears flat, but it's because of scaling. There was some significant increase there. When you look at the red, our adolescents increased fourfold, and for children 18 to 9 years, the mean number tested increased from 44.8 to 142, and all were significant. For yield, there was a six-fold increase in infants identified between October 2015 and September 2016. We also saw significant increases in identification of HIV-positive children and a more modest increase among adolescents. So among infants, use of family information table was significantly associated with increased HIV testing as an incidence rate ratio of 2.89, and as you can see, statistical significance at the p-values highlighted. For the 18 to 9 years, family information table chart audits were significantly associated with increased testing, and among adolescents, providing and innovating space for HIV testing and counseling was significantly associated with increased testing at an incidence rate ratio of 1.45. For infants, we actually saw significant number of infants being identified, and it was associated with the family information table at an incident rate ratio of 8.71. It's important to note that we did adjustments for repeated measures, geographical locations, and health facility tier. In conclusion, targeting family members of HIV-positive adults increases both identification, testing, and identification of HIV-positive. Now, one-time investment in improving HTC space may be an effective approach for increasing HIV testing among adolescents in this context. Significant increases in number of children tested resulted in only a modest number of new children identified with HIV, highlighting the need for multiple testing approaches. We wish to recommend that there is need to optimize the family unit to increase testing reach and care cascade entry. Consistent updating of family testing table and routine chart audits of the children files kept us on toes in terms of tracking and follow-up testing. There's need to consider structural improvements to facilitate testing, especially among adolescents. And finally, Combining strategies and continuously working to refine them will surely get us to the 90, 90, 90. I wish to acknowledge Ministry of Health, FACES, KEMRI, UCSF, and C4 funders, FACES staff, clients, and families, and to you participants for paying attention. Thank you.
Thank you very much, Nicola. Questions from the floor? Yes?
Yes, my name is Jan Harmon. I work for the AIDS Fund, Dutch NGO. I have a question on pediatric HIV in Kenya. As NASCOP presented their results lately, and they said they are almost at the 90, the first 90. They are now at 82%. So they miss out only 6,500 children nationwide. So they suggested to us to not work on pediatric HIV anymore, but to work on adolescents. So I would like to have your opinion as well, as well, we want to triangulate our insights on this.
Thank you for your question. It's difficult to contradict NASCOP being our advisors, but my honest opinion is that we are not yet there. So for me, any investment targeting in pediatric identification, I would promote. Thank you.
Thank you. And I also have a question for you.
Please.
So it's interesting to note that the structural improvements helped to bring the adolescents in, and probably along the lines of what we might think would be sort of adolescent friendly, but we also have heard from young people living with HIV at a workshop yesterday that the friendliness of the provider was very important. I was curious to know whether the structural improvements in the clinic were also accompanied with training for providers about how to reach youth.
Mm-hmm. Thank you so much. Currently, we tend to move slightly away from adolescent-friendly, services per se, to adolescent-responsive services. So, in our context, most of our providers have been trained on an adolescent package of care that involves even how to work with the adolescent. So when we did the structural improvements, we ensured that the staff that were within those spaces had that kind of training and were competent enough to address adolescent-related issues. Yeah. Thank you.
Good. Since we have time, I'll ask another question. So have you conducted any qualitative work that may give us a better sense of the acceptability of the testing, the different strategies, and whether, some strategies may be more acceptable from the end user perspective compared to others? Mm-hmm. I was curious to hear if you've thought about it a little bit.
Thank you so much. We haven't done qualitative per se on HTS, but we've done that on our third 90, and there were exciting findings we hope to share sometime. But then I think it's something worth doing. It's something we can think about and probably share. We haven't done that yet. Thank you.
Good. Thank you very much, Nicola.
Thank you.
Okay, we're now moving to our third presentation. We have today a small but strong male representation in our session. And so I would like to invite Fetch Kalembo from Malawi, Muzuzu University, to present his study entitled Disclosure of HIV Status to Children Living with HIV in Malawi, Needs Assessment and Formative Evaluation of an intervention intended to help with the disclosure process.
Thank you. Good morning. My name is Fetch Kalembo, as already being said. This morning, I'll present to you the results of my study, which has been like the results of part of my PhD program. I'll be completing my PhD program next month. So the results of that PhD programs, the ones that I'm going to present today. So The study that I conducted is about HIV disclosure in children. Specifically, this is a formative evaluation to test the need and acceptability of storybooks intended to help children know about their HIV status. Just a brief background of Malawi. Malawi is a country in the sub-Saharan Africa with a population of approximately 18 million, and approximately 1 million people are living with HIV. Of these, 10% are children. People living with HIV in rich countries are expected to live a normal life expectancy. On this basis, I also think that children living with HIV in Malawi can live a normal life expectancy if they lead a healthy lifestyle. Therefore, knowledge of their HIV status is critically important. Nonetheless, materials which are rigorously evaluated and standardized are scarce in Malawi. Therefore, the aim of this study was to evaluate the need and acceptability of culturally appropriate storybooks intended to help with the disclosure process. Should be noted that formative evaluation is intended for interventions that are yet to be developed, mostly in order to test their acceptability and suitability to the population. So the books are not yet developed, but we plan to develop the books in line with the cognitive and emotional development of children. This was a formative evaluation study using mixed method approach, and data were collected from primary caregivers of children living with HIV, healthcare workers working in ART clinics in all district hospitals in Malawi and central hospitals, teachers, these are primary school teachers, and community leaders. And we had several instruments that we used. Notable, we collected data on disclosure of HIV status, need and acceptability of HIV disclosure storybooks, and also collected data on the emotional and behavioral outcomes of children living with HIV. We used in-depth interview guide as well as focus group discussion guide to collect data for the quantitative part of this study. For the survey, we had two categories of participants, and we had 429 primary caregivers and 168 healthcare workers. And the results, almost 61% of the primary caregivers were biological mothers of children living with HIV. This shows that a considerable number of children might be living with a primary caregiver who is not a biological mother and are at risk of developing poor health and developmental outcomes. And about 50% of the healthcare workers were nurses. It also shows the situation on the ground in Malawi, where nurses and allied staff make up about almost 75% of the healthcare workers. In terms of HIV disclosure, about 64% were unaware of their HIV status. And reasons for non-disclosure of HIV status, mostly the top four, mostly were that the fear for negative consequences of HIV disclosure, like stigma and discrimination, lack of knowledge and confidence in HIV disclosure, lack of training, as well as lack of materials to use for HIV disclosure. In terms of factors associated with non-disclosure, younger children, children with normal weight, and those who are not asking for the reasons for taking ARVs were more likely not to know their HIV status. And notable among the healthcare workers, those who did not receive training were almost 8 times more likely not to disclose HIV status to children. Their views regarding the storybooks, almost all the participants supported the idea to develop the books, and they reported that they would use the books if they are developed. And they thought that the books would help them to improve their knowledge on HIV and also confidence on HIV disclosure. Moving on to the qualitative part of the study, we conducted 12 focus group discussions and 19 in-depth interviews among primary caregivers, healthcare workers, primary school teachers, and community leaders, and there were a total of 106 participants in this phase of the study. These were recruited from all administrative regions of the country. Their views regarding the storybooks, just as in the quantitative study, most of them expressed the need for the books, and in addition to improving their knowledge and confidence, they thought that the books will standardize the disclosure process in Malawi. And also they thought that the books would help to improve relationships among stakeholders, because at that point in time, healthcare workers, teachers, community leaders, primary caregivers, they are working in isolation. So they thought that they would be able to work together to support children living with HIV with the books. And suggestions regarding the storybooks, they thought that we should include nutrition, medication compliance, and also beautiful pictures just to attract children to read the books. And they also thought that we should not include scale pictures as well as sexual references. In terms of sexual references, they thought that it's against their culture, so they thought it would not be important to include that. And they also suggested that we should include training once the books are developed. In conclusion, we have found that the majority of children living with HIV between the ages of 6 to 12 years in Malawi are unaware of their HIV status because of fear of negative consequences of HIV disclosure, lack of knowledge and confidence in HIV disclosure, and lack of standardized disclosure materials. And also, we have also learned that there is a high acceptability and high need for the storybooks. And also, there is also a great need for the stakeholders, primary caregivers, health workers, teachers, to work together in supporting children undergoing the disclosure process. The next phase is to develop the books, the storybooks, pilot them, and depending on the outcome, to scale up the interventions throughout Malawi. Special thanks to Curtin University for sponsoring the study, and also the Ministry of Health in Malawi for the support during the preparation of the study and during data collection, and also the participants, and also the audience here. Thank you.
Thank you very much. So now the paper is open for questions. There is a question up there.
Thank you very much for a great presentation. My name's Jenny Renju from London School of Hygiene and Tropical Medicine. I commend you on the breadth of your formative research, and you're obviously including a lot of people. I just wonder why you haven't maybe included the youth, the children themselves, in terms of them doing some drawings and to try and explain their stories. I know I'm based in Tanzania, and I know a bit of this work has been done in Tanzania as well. And that could also help with your illustrations as well in the storybooks. So I wonder if that's part of the plan.
Thank you for that question. It's a really good question. We did include mostly adolescents who are like leaders for the teen clubs, and also for other associations that are to do with children living with HIV. So they also had their input, and we included them in the group of community readers. So we did include them. Yeah.
And I have a second question. So you focused on the age group of 6 to 12.
Yes.
In my context in Asia, families are very hesitant to disclose to the sort of younger children. So did you have discussions about variation between partial disclosure versus full disclosure, or is it the practice in Malawi to disclose in this age group, fully disclose in this age group?
Thank you for the good question. Actually, we based that 6 to 12 years based on the WHO guidelines that says that children living with HIV should be completely taught about the HIV status within the ages of 6 to 12 years. That's why we had that age range. Yeah, thank you.
Good. With that, thank you very much.
Yeah.
With that, I'll hand over to my co-chair.
Okay. So we're coming back to the topic of HIV testing, and we have Kathleen Sindelar from the Clinton Health Access Initiative in Lesotho, who's going to talk about community-based HIV testing there.
Thank you so much. It's an honor to be here presenting on behalf of my co-author team back in Lesotho and, of course, the implementing partners. And I'm here to share findings on the effectiveness of reaching HIV-positive children through community-based testing in Lesotho. So Lesotho is a small landlocked country completely surrounded by South Africa, and it's in the midst of a health crisis with 23% of its 2.5 million citizens infected with HIV. And prior to project commencement in 2014, data showed significant gaps in the prevention of mother-to-child transmission and early infant diagnosis programs. And this resulted, as you can see here, in just 30% ART coverage amongst children 0 to 14 years old. Due to the absence of consistent HIV testing opportunities beyond the facility, we identified community-based testing as a solution to reach more people with these life-saving services. The Mobilizing HIV Identification and Treatment Program commenced in October of 2015, and it is currently ongoing in the 2 districts with the highest HIV prevalence and unmet HIV testing needs. And our project has 2 objectives, and the first is to use community-based testing strategies to rapidly identify undiagnosed or lost HIV-positive children 0 to 14 years, pregnant and breastfeeding women, as well as HIV-exposed infants. And our second objective is to support linkage to care for all of these individuals who are found HIV positive in the community and link them to care. So the project identified 6 testing strategies specifically to target children. The first of these are mobile outreach clinics, and this brings a wide range of health services to rural communities on a monthly basis. And this is the only strategy that's providing dried blood spot collection, as well as ART initiation and ART refills. Next, we have targeted testing, and this brings HIV testing services to venues thought to have children who are at high risk of HIV infections, such as orphanages. Our next strategy is community testing, and this is where a tent is erected in a high-traffic pedestrian zone, and HIV testing is offered to anyone who's interested. Next, we have facility index testing, and this is when we have a counselor who is based full-time at the facility, and this is in order to receive consent from ART patients who are coming for their monthly refills in order to provide home-based testing to all of their household members. And it's through this strategy that door-to-door testing emerged as a way to conceal the targeted strategy of facility index testing. And this is where HTC is offered to all the surrounding households of the indexed patient. And then again, our door-to-door index testing evolved from that. So when we are doing door-to-door testing and an individual identifies as HIV positive, all of their household members are then indexed and tested. A mobile application was built specifically for this project in order to capture patient data at the point of care. And this was just done so for the newly identified exposed infants, HIV-positive children, and pregnant and breastfeeding women. And this data included our basic patient data, the details of the testing event where the child was identified positive. We also wanted to learn more about the mother's ART status when this was available, as well as the facility attendance history and the testing history of the child at the point of enrollment. From December 2015 to April 2017, nearly 50,000 children were tested in the community, and 206 tested positive out of these. And this gives us a yield of 0.43%. And although this yield was considerably lower than what was anticipated, we see that the facility yield over the same time is also quite low at 0.85%. We see in this chart that our mobile outreach clinics accounted for the most tests as well as the most positive tests. However, our yields were highest amongst our index testing strategies, except it's very important to note that our facility index reached 631 kids, and in the same period of time, this door-to-door index reached 9 times as many children. What's also important to note, and this seems a bit contradictory to our first 2 presentations, is that our targeted strategies did not yield or did not result in higher yields than those that were not targeted. So we found the most children between 5 to 9 years of age. However, overall, 60% of the children that we found positive were over the age of 5 years, which is really exciting because I think these children are harder to find through facility-based testing. Again, we see that mobile outreach clinics were very effective at finding children of all ages, and this was unexpected due to the fact that they're just operating during school hours. And this really suggests to us that communities are embracing these mobile outreach clinics and really using them as a replacement for facility services. We also see that both door-to-door testing strategies were effective at finding children who were over 5 years of age, and this is partially attributed to the fact that they were working on nights and weekends. Overall, we found similar ratios of male to female amongst all age categories. So immediately here, with this huge red chunk, we are seeing that 70% of the children that we are finding positive through community-based testing had never been tested before. We also see that DBS coverage was higher than rapid, which is quite unexpected given that it's a much more complex process and that it's much more targeted to 18 months and younger. And next, we wanted to break this down by age category to really understand the effectiveness of reaching these hard-to-find children. And we see that as age increases, our previous testing history significantly decreases. And this is showing us that older children continue to be more frequently overlooked than those that are under 5 years of age. Excitingly, though, we do see that our EID coverage has increased significantly, with here only 24% of our children 0 to 1 years had never been tested before. So next, we wanted to examine the facility attendance history for these children at the point of enrollment. So only 49% of the children who were found positive had any kind of known facility attendance history. And when we look at the overall results, let's see, well, all the way over to the left, there's a pretty even breakdown, but we do see that the majority of children had not been to a facility in over 1 year. Again, we see that all children 0 to 1 years had been to a facility, which is fantastic, but these numbers really dwindle as the age increases again, even within the next age category of 2 to 5 years, which is quite surprising, given that routine growth monitoring and other services should be received by children around this age. And last, we really wanted to understand the impacts of community-based testing in relation to linkage to care and retention of these children. So we see wonderful outcomes in that 70% of the overall children are linked to care and initiated on ART. We had 6% who had not been followed up yet, 18% who were never found at the facility and unable to be traced, 2% who had died, and 4% who had transferred out to another facility that was not supported by the project. Again, we want to break this down by age to get a more nuanced understanding of this impact. And we see that there's 87% overall retention in care at 3 months of these children, which is very exciting and very much aligned with the facility outcomes. And it was the highest loss point was amongst those who were 0 to 1 years old. So what I really want you to take away from this presentation is that community-based HIV testing and counseling is effective at finding those children who are very hard to reach, the children who are not showing up at the facility or are somehow being overlooked for these life-saving services when they are in the facility. And this is going to be an essential strategy for us in achieving the first 90. We also see that community-based testing was effective at finding children who had never been tested before, as 70% of our children had no testing history. We also see that it's effective at finding children who are generally harder to reach, and that is the children who are over 5 years old. We see that children over 5 are much more frequently overlooked for HIV testing and counseling than children under 5 years old. And lastly, we've learned that community-based HIV testing and counseling does not pose a significant barrier in linking a child to care and keeping them in care. And I'd really like to thank my co-author, Jessica Joseph, my team back in Lesotho at the Clinton Health Access Initiative, and especially our implementing partners, and that's the Ministry of Health, Vodafone Foundation, Baylor College of Medicine Children's Foundation Lesotho, Population Services International Lesotho, and Riders for Health Lesotho, but really most especially our counselors and nurses who are working tirelessly in the field to bring these life-saving services to the communities. Thank you.
So now we'll take questions at the microphones on either side of the room. First question.
Lynn Wilkinson, that was very interesting. I'm just wondering, for some of us that might not have the same amounts of resources, and we had to look at which of, because you had to test a lot of children to find those 200. I was wondering, you got sort of the biggest yield from the door-to-door index testing. Do you think that could potentially be an add-on for people that are already doing community testing strategies, mostly focused on adults, that once they identify a positive, there could be a sort of backup team that could do index testing for the children, and that might be one strategy which would be highest yield with not having to test quite so many children. I was just wondering, looking at your numbers, if you thought that sort of strategy might work if we aren't able to do all 6 testing strategies.
Absolutely, that's a great question. Thank you. And I do think that's a great suggestion, is to always index every member of a family and not just certain ones of those patients who are found positive. But I also think it's important to note that really in resource-limited settings, I would recommend just the door-to-door testing, and that's where the door-to-door index testing emerges from anyway. But it allows you with the least resources to reach the most amount of children. And what was interesting is that we didn't discriminate. We focused on children, but we tested everyone. And through these community-based testing strategies, 50% of the people we found were naturally 0 to 14 years old. So, yes.
First
Great.
microphone on the left.
Hi, my name is Julia Robinson, and I'm with Health Alliance International in Cote d'Ivoire and the University of Washington. I have two questions. One's really quick. For the mobile outreach clinics, did they offer other services other than HIV testing, or was it just a testing clinic? And then my second question has to do with your data collection tool in the app. I'm wondering how much of that data is duplicative with what the normal routine data would be collected, I guess, within the broader health system, maybe with the Ministry of Health, and kind of what are your thoughts on I'm always kind of skeptical of mobile apps in terms of data collection, just because I don't know how integrated they are with the national system.
Yeah, thank you for the great questions. So the mobile outreach clinics, as much as possible, we offered as many services as the facility were offering. So we offered OPD, under 5, ANC, vaccinations. So I really think that this is a strong strategy for value for money, because it's really coming whole circle with everything that these communities need. And then, of course, thank you, because we're all, I think, concerned about overburdening healthcare staff with more data collection. And so really a lot of the indicators that we were collecting are not anything that the Ministry of Health is collecting. So of course, the basic patient demographics is a bit of a duplicate. However, like the testing history and mothers are, yeah. But we tried to make it different, and we also placed a lot of importance on timeliness and user-friendliness of this application. So our staff are really able to collect all of this patient data in 5 minutes or less. So it's not a very time-consuming process.
And we'll have 2 more questions, first in the back and then come back to the front.
Sophie Lecoeur, French Institute of Demography. Do you have an estimation of the proportion of children who were infected through mother-to-child transmission?
So we see that our prevalence is, on the first slide, I think about 2.8%. But other than that, I can look that up and tell you after the presentation.
Thank you.
Thanks.
Front microphone.
Hi, Elaine Abrams, ICAP at Columbia. I'm curious about the mother status, particularly of the kids under 5, and whether their moms knew they were positive, whether these were women who didn't get tested, or whether we failed to keep the kids of these women who knew their status.
Yes. So that's a great question. Thank you. We found just over half of the mothers were already on ART. So it was a pretty good mix of those who were also newly identified at the same time and those who were not. But interestingly, and I didn't have time to reflect this data in the presentation, we actually had more children who were accompanied by female family members rather than their actual mothers as well. So even though that's a very important factor, I think we need to also think beyond that children are not always going to be with their mother.
And we have one more quick question from Dr. Chewe.
Actually, I'm asking it on behalf of...
Oh, microphone. On your right.
Oh, right, sorry. I'm asking it on behalf... She's just wondering why you didn't think about immunization as an entry for children, and whether in Lesotho they actually do outreach for kids, and whether that's a more viable approach to reaching more children in the community.
So we did offer immunization at our mobile outreach clinics, and this was really the only time out of the 6 strategies that it was appropriate and that we had the staff who were trained and the resources to bring this service to the community. But this was certainly a focus at our mobile outreach clinics. Our focus was on under 5 services, and that included vaccinations. And I think that was a very important part of actually getting these children, these 25,000 children to the outreach clinics, is that they're not necessarily coming for the HIV testing. That's really an added bonus to the other services that they're receiving.
Thank you, Ms. Sindelar. And now we're going to have the first of 2 cost-effectiveness analyses. The first one will be given by Simone Frank from Massachusetts General Hospital in the United States, looking at early infant diagnosis testing using point-of-care technologies.
Thank you so much. Good morning, everyone, and thank you to the organizers for inviting me to speak. It's a real pleasure to be here presenting on behalf of my co-authors. I have no disclosures. Nearly 1.4 million children were born to HIV-infected mothers worldwide in 2015, and 150,000 children became newly infected. Although the WHO recommends EID testing at 6 weeks for all infants born to women living with HIV, less than 50% accessed EID testing by 2 months of age. Most conventional EID programs currently use laboratory-based PCR assays. However, conventional EID presents several challenges, including long times for transporting specimens to the lab and for returning results to clinics, caregivers, and patients. This often results in substantial loss to follow-up even before result return. Incorporating point-of-care assays into EID testing may help address the challenges associated with conventional EID. Point-of-care EID testing may lead to an increase in access to testing and quick on-site screening. Additionally, it may reduce result return times, increase the percentage of results returned to patients and caregivers, and enable rapid linkage to ART. We're working in collaboration with the Elizabeth Glaser Pediatric AIDS Foundation and Unitaid, who have launched a joint initiative to roll out point-of-care EID platforms in 9 sub-Saharan African countries, and are currently undertaking a pilot project in Zimbabwe. Our objective was to project the clinical impact, cost, and cost-effectiveness of integrating point-of-care assays into Zimbabwe's national EID network. We used the cost-effectiveness of preventing AIDS complications, or CPAC, pediatric model, which is a widely published mathematical model of pediatric HIV disease, infant HIV transmission, and EID testing. It simulates individual-level clinical events, including HIV detection via EID testing or opportunistic infection, tracks disease progression using CD4 and viral load, and models treatment response. The model uses existing data to project longer-term clinical and economic outcomes. We modeled a cohort of HIV-exposed infants undergoing EID testing in Zimbabwe. Within this cohort, we examined 2 strategies: conventional or laboratory-based EID and point-of-care EID. We projected outcomes separately for HIV-infected infants, as well as the entire birth cohort, which included both HIV-infected and HIV-exposed uninfected infants. Our projected outcomes included 1-year survival, life expectancy, and per-person HIV-related healthcare costs. We used cost-effectiveness analysis to assess the comparative value of point-of-care EID versus conventional EID. To do this, we calculated an incremental cost-effectiveness ratio, which measured the difference in cost over the difference in health benefit between the 2 strategies, expressed in dollars per year of life saved. It's important to note that cost-effective does not necessarily mean cheap or cost-saving, but that the additional health benefit is worth the additional cost. We compared our incremental cost-effectiveness ratio to the Zimbabwe per capita GDP of $930. We defined an incremental cost-effectiveness ratio, less than 1 time GDP per year of life saved, as cost-effective, although we recognize that there is ongoing research to identify appropriate cost-effectiveness thresholds. For our model inputs, we modeled conventional assays with 100% sensitivity and 99.6% specificity at a cost of $14.50 per test. We modeled point-of-care assays with 96.9% sensitivity and 100% specificity at a cost of $21 per test. Result return time for conventional EID was 1 month, with a 71% probability of receiving a result and linking to care. Result return time for point-of-care EID was immediate, with a 97% probability of receiving a result and linking to care. And now we'll turn to the results. This graph depicts early survival amongst HIV-infected infants, with HIV-infected survival percentage along the vertical axis and age in months along the horizontal axis. The blue line represents point-of-care EID, and the green line represents conventional EID. The arrows mark the points at which infants received their results and linked to ART in each of the strategies. Compared to conventional EID, point-of-care EID led to a 4.5% increase in survival by 4 months of age. 1-year survival is shown in the bottom right corner of the graph. At 1 year, survival for HIV-infected infants was 71.5% for those who received conventional EID and 76.5% for those who received point-of-care EID. In lifetime projections, conventional EID led to an HIV-infected life expectancy of 23.8 years and an entire birth cohort life expectancy of 60.1 years at a lifetime cost of $860 per infant. Point-of-care EID led to an HIV-infected life expectancy of 25.5 years and to a birth cohort life expectancy of 60.2 years at a lifetime cost of $930 per infant. Using costs and life expectancy values discounted at 3% per year, the incremental cost-effectiveness ratio of point-of-care EID versus conventional EID was $750 per year of life saved. Point-of-care EID was cost-effective compared to conventional EID. We conducted extensive sensitivity analyses on all key parameters, including those specific to each strategy, such as assay cost, sensitivity, and specificity, and those applying to both strategies, such as care costs and prevention of mother-to-child transmission coverage. We found that point-of-care EID was no longer cost-effective if fewer than 75% of infants undergoing point-of-care testing, or greater than 96% of infants undergoing conventional testing, received test results, or if fewer than 80% of infants linked to ART after receiving point-of-care results. Additionally, point-of-care EID was no longer cost-effective if point-of-care assay sensitivity was less than 85%, if specificity was less than 92%, or if assay cost was greater than $40. The slightly lower sensitivity of point-of-care assays compared to conventional assays has been an important concern. However, point-of-care assay sensitivity must be weighed against the rates of conventional EID result return, because both low sensitivity and low result return result in missed diagnoses. Here, we show how the cost-effectiveness of point-of-care EID changes when we vary point-of-care assay sensitivity on the horizontal axis and the probability of result return with conventional EID on the vertical axis. The green cells indicate where point-of-care EID is considered cost-effective compared to conventional EID, with an incremental cost-effectiveness ratio value below the threshold of $930 per year of life saved. The black square marks the base case value in the upper right. For comparison, the lowest reported value for point-of-care sensitivity and the highest reported value for conventional result return probability are shown in the black circles. Overall, we found that large improvements in conventional assay result return probability were needed to offset slightly lower point-of-care assay sensitivity. Our analysis has several limitations. First, we only examine EID testing at 6 weeks of age. There are currently limited data about the resources required to implement or expand point-of-care EID programs and how exactly point-of-care will affect EID cascade outcomes. Additionally, multiple factors may further decrease point-of-care costs, such as increased demand or pooled volume negotiations, making it more cost-effective. Finally, while our clinical outcomes may be generalizable across sub-Saharan Africa, costs and cost-effectiveness outcomes are specific to Zimbabwe. In conclusion, timely return of EID test results is critical to averting infant mortality in the early months of life. Incorporating point-of-care assays into EID programs at 6 weeks of age in Zimbabwe will improve survival and life expectancy and will be cost-effective compared to conventional EID. I'd like to thank the rest of the CPAC Pediatric team as well as our funders. Thank you.
Okay, we are now open for questions. about the cost effectiveness analysis and the results? So question here, please.
Yes, thank you. My name is Sarah Fidecario-Kessler, and really helpful presentation, and I apologize if I missed this in the beginning, but what point of care technology was this Cepheid Gene Expert? And if you could comment on what went into that $21 cost.
Sure. So we modeled the rapid PCR tests such as Alere or Cepheid, and the test cost was a total cost of ownership from the Global Fund, and this included the test kit, the machine, logistics, setup, training, installation, and service costs.
Thank you. Question here on the right.
Yes. How did you estimate the expectancy life for HIV-infected children? I saw something like 23 or 24 years, and I am a bit surprised when you have art early in life that you have not a better expectancy, even in Africa.
Right. So life expectancy is a very it's a difficult outcome because there's no empirical data currently to compare it to. So we've performed many natural history and on-art model calibrations and have validated our survival to short-term outcomes and then have extrapolated to long-term outcomes. So our short-term outcomes, they've been calibrated to large cohort studies, so primarily from IDEA East African region data and Cape Town AIDS cohort studies. And again, thank you for the question, but we have validated to short-term survival and then extrapolated out to estimate life expectancy values.
Yeah, just a quick question regarding the placement of POC. We know that the ECPAF project is looking at different models. So in the context, for example, of the hub and spoke model, does your analysis capture that in sensitivity analysis in terms of result return, in terms of cost, and so on and so forth?
Right, thank you. So we did not separately model hub and spoke sites in this analysis. That is certainly something that we are capable of doing, and that can sort of be reflected in the sensitivity analyses that we've done looking at, for example, lower linkage rates, which could be reflective of testing in a more rural setting where there isn't that immediate access to art. But in the data that have been presented earlier this week by my colleagues at EGPAF, they've really found that there's not a considerable difference in those outcomes such as result return and linkage to art between the hub and spoke sites.
Thank you, Ms. Frank.
Thank you.
So our second cost effectiveness analysis is also a late breaker, which will be presented by Caitlin Dugdale from Massachusetts General Hospital and the Brigham and Women's Hospital in Boston. It will be focused on South Africa in this case. Dr. Dugdale.
Thank you so much to the organizers for the invitation to present, and thank you to all of you for sticking around on this last day of the conference right before lunch. I really appreciate it. We have no disclosures. High rates of postpartum maternal loss to follow-up and antiretroviral therapy not adherence contribute to adverse maternal and pediatric outcomes, as well as to mother-to-child transmission of HIV among breastfeeding infants. In South Africa, by 12 months after delivery, 25 to 30% of mothers living with HIV are lost to follow-up. For those who remain in care, only 70% are virologically suppressed. Transfer of care from antenatal maternal and child health services to separate postpartum maternal ART clinics and infant HIV and well child care is a particularly vulnerable time for loss to follow-up. To address this key vulnerability, the strategies to optimize ART services for maternal and child health, or MCH-ART trial, examine two strategies: routine care, with referral to separate maternal ART and infant HIV and well child care postpartum, was compared to the integrated care intervention of co-located maternal ART and infant care integrated into the maternal and child health platform through the end of breastfeeding. Results of integrated care were improved maternal retention and care and viral suppression at 12 months, longer breastfeeding duration, and low mother-to-child transmission rates at 1 year, rates that were similar in both trial arms. Our objective was to use the MCH-ART trial data to project the long-term clinical impact and cost-effectiveness of the integrated care intervention compared to routine care for postpartum mothers and infants in South Africa. We model, or I'm sorry, as my colleague Ms. Simone Frank just discussed in the last presentation, we use the widely published Cost Effectiveness of Preventing AIDS Complications, or CPAC International and CPAC Pediatrics, Monte Carlo simulation models of adult and pediatric HIV. We simulated individual mothers and infants from delivery through death. The models incorporate mother-to-child transmission with risks stratified by breastfeeding status and ART use, HIV progression, including viral load and CD4 count, ART adherence, loss to follow-up, and return to care. These models use inputs derived from the published literature and clinical trials to project long-term clinical and economic outcomes for mothers and children. We modeled a cohort of postpartum mothers living with HIV and their breastfed infants in South Africa. We evaluated the 2 MCH-ART trial strategies, routine care, which involved referral to separate maternal ART and infant care after delivery, and integrated care, which reflected co-located maternal ART and infant care in maternal and child health services until the end of breastfeeding. Model-based outcomes included mother-to-child transmission rates, maternal and infant life expectancy, and per-person HIV-related healthcare costs. In this cost-effectiveness analysis, we calculated the incremental cost-effectiveness ratio, or ICER, of integrated care compared to routine care. The ICER represents the additional resource use divided by the additional health benefit measured in US dollars per year of life saved. We considered an ICER of less than 1 times per capita GDP per year of life saved to be cost-effective, meaning that the additional health benefit is worth the additional cost. This cost-effectiveness threshold was therefore equal to the 2016 South Africa GDP at $5,260 per year of life saved. We derived key model inputs from the MCH-ART trial. Mean maternal age was 28.6 years. CD4 counts were less than 350 before ART initiation in 49% of mothers. The time on ART at delivery was a median of 4.3 months. Retention in care at 1 year in routine care was 71% and improved to 81% with integrated care. HIV viral load was suppressed at less than 50 copies per milliliter at 1 year in 49% of women in routine care, which increased to 66% of women in integrated care. Mean breastfeeding duration in routine care was 6 months and rose to 8 months in integrated care. We used an additional integrated care intervention cost of $200 per mother-infant pair based on preliminary costing data. And now we turn to the results. As you can see in the first column, pediatric outcomes were identical between arms with 1.7% total mother-to-child transmission. For the combined cohort of HIV-infected and HIV-uninfected children, pediatric life expectancy was 62.4 years, and total HIV-related costs were $290 per person. Maternal life expectancy from delivery in routine care was 26.5 years and higher in integrated care at 27.3 years. Maternal HIV-related costs in routine care were $21,920 per person and increased to $22,570 per person in integrated care. In the cost-effectiveness analysis, the ICER of integrated care compared to routine care was $1,050 per year of life saved. This ICER is less than 20% of South Africa per capita GDP and is considered to be cost-effective. The modeled outcomes capture key trade-offs with breastfeeding in terms of mother-to-child transmission and overall infant survival. As you can see on the left, integrated care led to improved maternal viral suppression, which decreases the risk of mother-to-child transmission. This decreased risk is balanced on the right by longer breastfeeding, which may increase the risk of mother-to-child transmission, but may also decrease infant non-AIDS-related mortality. We performed a sensitivity analysis around breastfeeding duration and mother-to-child transmission. With the duration of breastfeeding observed in the trial, 6 months in routine care, as shown in the blue dotted line, and 8 months in integrated care, as shown in the red dotted line, total mother-to-child transmission was 1.7% in both strategies. If the mean duration of breastfeeding were 12 months in both strategies, as endorsed by the WHO, mother-to-child transmission was projected to be 2.4% with routine care and decreased to 2.1% with integrated care. Integrated care was increasingly cost-effective with longer durations of breastfeeding. If the mean duration of breastfeeding was 12 months in both arms, the ICER was actually lower than in the base case at $990 per year of life saved. We conducted additional sensitivity analyses around other cost and effectiveness parameters. Integrated care was cost-effective unless the intervention cost was more than $2,360 per mother-infant pair. However, this value is unlikely to be reached at nearly 12 times the estimated cost of the intervention. In terms of effectiveness, integrated care remained cost-effective even if the impact on retention and virologic suppression were reduced by 50%. With 50% reduced effectiveness of the integrated care intervention, the ICER was still $1,310 per year of life saved. Our analysis has a number of limitations. First is, with any model-based analysis, there's uncertainty inherent in long-term projections. There are limited data on maternal retention and adherence beyond just a few years postpartum. Also, repeat pregnancies and their potential impact on maternal re-engagement in care were not considered. Exact intervention costs are not yet known, but a detailed costing study of the intervention is actually being conducted by our colleagues Lucy Kunama and Adina Sinanovic at the University of Cape Town. Lastly, in this analysis, the costs and cost-effectiveness outcomes are specific to South Africa and may be different in other settings. In conclusion, co-located maternal ART and infant care integrated into maternal and child health services through the end of breastfeeding is a cost-effective strategy to optimize postpartum maternal and infant outcomes in South Africa. I would like to acknowledge the other members of the CPAC Pediatrics team, the MCH ART team, and our funders, all of whom are listed below. Thank you.
Thank you for your presentation. We're open for questions, and we'll start with Martina.
Thank you very much for the nice presentation. My question is about to what extent does your analysis capture the potential cost or impact on non-HIV outcomes? And so it's just to try to understand, how there could be benefits, not just from the HIV perspective, right? And I can't remember now what the trial was looking at exactly with that respect, but so I was curious to see whether you've considered that and how that's captured in the model.
Right, thank you. That's a great question. And I think, we're still doing a lot of work to try to capture all of those non-HIV related indirect benefits, both to mother and child. For instance, at the talk on Sunday, the HEU workshop, there was some great data presented about the impact of breastfeeding on reduction of HEU mortality. And for this base case analysis, we try to be very conservative in our assumptions. And so we've assumed virtually no benefit from breastfeeding, but we know that that's not accurate. And so in our sensitivity analysis, but also as we incorporate some of the data from this conference, we'll be able to better hone our results to reflect some of those other perhaps non-HIV related benefits to both mom and baby of this sort of intervention. Does that answer your question? Great, thank you.
Right in the back.
Hi, Jeannie Collins from UCL. Very nice talk. I was just surprised at the very low rate of transmission of 1.7. And I just wondered, I'm sorry that I'm not familiar with the trial, whether this was restricted to mums who presented quite early in ANC and you didn't have late presenters. And I guess also in light of the relatively high proportion without suppression, and maybe they weren't suppressed under 50, but most were suppressed under 400, and if you had frequent viral load monitoring and switching for the non-suppressed.
Excellent set of questions there. Thank you so much. The very low mother-to-child transmission rates, I think, have everything to do with the trial structure. So moms in the MCHR trial were recruited in the antenatal clinic setting and were newly initiated on ART. They were on average, well, had a median of 4.3 months of ART before delivery, and so a relatively high percentage of them were suppressed. I think about 73% were suppressed at delivery. So that certainly contributes to the low mother-to-child transmission rates. Infant prophylaxis was also used in this setting, and we did not model a separate population of only late presenters or women who had not received ART during antenatal care, though those will certainly be things that we evaluate in our sensitivity analyses. Thank you.
Thank you, Dr. Dugdale.
Thank you.
And so we've heard about ways to increase testing of children and adolescents, as well as promote linkage to care and disclosure to those who are diagnosed. And now we have some cost-effectiveness data to support funding testing initiatives, as well as efforts to integrate maternal child health services. So please join me in thanking our panelists for today. And they will be available up here for a few minutes for anybody who has any additional questions. And thanks to Martina and all of you. Enjoy the rest of your conference day.